What's up? It's your favorite NPHP. So this video was a requested video, and the question was, when will the nurse call the doctor or the resident or the intern instead of me, the NP? Before we jump into this video, for all of you guys that are new to this channel, welcome. Just to give you just a quick little background, I am a nurse practitioner, a hospitalist, a nocturnal hospitalist NP. I've been working for now a little over a year, about a year and 3 months, and basically this channel just tells you guys about my journey, and whatever question you guys have, I answer. So welcome. So back to the question. So when will the nurses call the doctors, residents, or the intern, and not me? So first off, the hospitalist team I work for, we do not have any residents or interns. So at night we run with 4 attendings and 1 NP, and our service is 175 patients, and I cover, out of that 175 patients, I cover a 38 bed unit and my 12 bed observation unit. So just for you guys to understand that part first. So we do not have residents, interns on our team. It's only the attending and me. And while I cover my 38 bed and my 12 bed observation unit, there's one attending that is assigned to me that I go to if I have any questions. When an NP is on during the night, we are first call. So no matter what, we are first call. So if some reason I am not receiving the pages, the nurse may then go to my attending. We get all the pages, all the calls, any concerns, questions, concerns, anything comes directly to us regarding the patients that I'm covering. So regarding the 38 bed unit and the observation unit. So again, we are first call. So with that being said, the question actually comes down to, when do I feel that I need to call the attending? So basically, like, I take care of everything. If you could watch my last video about the pages I receive during the night. The pages I receive during the night, I correct those. Any of the pages, low blood pressures, high blood pressures, acute pain, acute abdominal pain, falls, I get called first. I go to the bedside, I do my bedside eval, and I come up with a plan on my own. So like I said, the question is, when do I feel that I then need an attending? So basically, I try to correct whatever the situation is on my own. If I'm busy with other things, if I'm busy with another bedside evaluation and an admission, and somebody else comes to me with another acute problem that I know I physically cannot manage at this time, I will call the attending to help me. So I got to give you an example. If I basically is correcting a blood pressure, I did everything that I could to correct the blood pressure, and this patient blood pressure still remains low, I will phone in the doctor. I will call in and tell them what I did. I'll give them my little quick presentation about the situation that's going on, what I did, and I'll ask them, what do you guys recommend next, just to get their thoughts and ideas. So when I feel that I truly cannot handle the situation on my own, I call the doctor. Usually I will get a gut feeling, or right off top, I could just feel and I know this patient's bottoming out quicker than normal. At the same time, we do have a ERT, emergency response team. With the emergency response team at my facility, nurses could call it, family members can call it, the patients can call it, I can call it, the doctor can call it. Anybody can call it. With this emergency response team, the nurses come to bedside, the doctors come to bedside, respiratory therapists come to bedside, and our stat nurses come to bedside. So everybody basically huddles around, and now we could all critically think and see and figure out what's going on with this patient. So I usually tell the nurses, if you guys feel you need to call ERT, call it ERT, because it just helps. It's helping everybody. We get more bodies at the bedside, which means more thinking, and whatever's going on with the patient could be corrected quicker, because we have everybody there and chiming in and giving their opinions and what they think is going on and things like that. So usually when nurses come up to me and say, I think we need to call ERT, I tell them call it, because if you think you need to call ERT, I know that I cannot manage the situation by myself. When an ERT is called, an attending doctor is required to be at bedside. But before ERTs are even called, and all the normal pages that I get during the night, I handle them by myself. If the problem still persists and I done everything that I felt that I've done, then I call the doctor and say, hey, what else can we do? What else you think needs done? I did this, I did that, and they will help me out. But you have to feel comfortable asking for help, because we are liable for so many patients now. Don't be afraid to call, because I'm not afraid. I'm not afraid to call for help, especially if I tried everything that I've tried and I present to them the case and they understand my train of thought and why I went about doing it this way. And I have not experienced a situation that the doctors questioned my choices of treating and how I went about treating something. So honestly, it's like, basically it's when I feel uncomfortable or when I get that gut feeling that, yeah, I need the attending nearby. And sometimes I may not even have that gut feeling. I just still will just call them. Just give you a heads up. Especially if I feel somebody may be tanking, I usually just call the doctor and give them a heads up. Like, hey, this patient has a low blood pressure. I'll just give you a heads up. They have the history of this, history of that. I'm giving them this fluid. I'm giving them this bolus. We're rechecking. But just to give you a heads up, if an ERT is called, you are aware that, you know, I'm handling it. So I like to do that just so they're not blindsided. Like, how come, Harry, you didn't tell me, you know, one of your patients were tanking? So where I work, I am first call. I manage all the issues, all the issues that occur throughout the night with my patients. I try to correct them on my own. If I feel that I cannot correct them, I call the doctor. Or, like I said, I give the doctors a heads up. If I feel that this can go the wrong way fast, I give them a heads up, like, hey, I'm doing this right now. But if an ERT is called, you know, they're already aware. So, yes, and again, this comes with a lot of experience. I'm sitting here talking the way I'm talking now after a good old year of experience doing this job. And like I mentioned in my other video, this is the rewarding part of my job. The critical thinking, me having to, by myself, go and look through a patient's chart and trying to put together a story and figure out why this patient may be having chest pain, why this patient needs a new O2 requirement, why is this patient having fevers, or why is their white count 40, things like that. So with that being said, I hope you enjoyed this video, and again, please give this video a thumbs up. It helps me know that you guys are liking this content. Don't forget to subscribe, and turn on that notification. And until next time, see you later.